Hello everyone. This is a research about physicians' imaginaries of AI and how they manifest in clinical and research workflows in oncology. This work is an interdisciplinary collaboration between human-computer interaction, AI, and oncology researchers. The central thesis of our work is that the lack of adoption of AI in clinical settings is due to the overlooked yet profound differences in clinical and research practices in cancer care, and the resulting tensions between what AI currently is and what physicians want AI to be. To address this issue, we have scrutinized the current enablers that afford AI a specific position within cancer care, and in what ways they are incompatible with established medical protocols and practices. In recent years, significant and rapid advancements in cancer research have been attributed to AI, which has shown to outperform human experts in diagnosing cancer and successfully detecting tumors at very early stages of development. Despite these positive developments in cancer research, the adoption of AI in clinical settings has been very low. In many cases, AI and machine learning models were considered problematic for safe clinical use and were not considered reliable by physicians. Consequently, our work contributes by providing contextual insights into physicians' use of and interactions with AI within their clinical and research workflows, and also by extracting physicians' imaginaries of an appropriate positioning of AI. Our research is grounded in the notion of imaginaries, which was developed by Cornelius Castoriadis, who is a social constructionist in the 1970s. In recent years, imaginaries, as a dimension of society, has been considered a recent subject of reflection and discussion, especially in the social sciences and philosophy. It is defined as a set of ideas, items, or images that define what is imaginable for a given individual or a collective subject. Essentially, it represents a commonly shared network of concepts, images, stories, and myths that enable common practices and provide a sense of legitimacy. In order to capture the imaginaries of physicians in oncology, we interviewed 7 senior physicians who use AI and machine learning in both their clinical and research workflows. Each interview lasted for approximately an hour and asked, among other things, how do physicians currently use and interact with AI, and the associated challenges, concerns, and opportunities with their use of AI, and also their imaginaries about the more fitting role of AI in cancer care. Our findings show significant differences between the clinical and research workflows in cancer care. They fundamentally differ in their intentionality and scope. On the one hand, clinical practices are known for their curative intent and an individualistic scope that puts the spotlight on a single patient whose treatment is very specific and is based on numerous attributes. AI is primarily used by physicians to test their hypotheses about the disease, its severity and progression, and to prepare diagnosis and prognosis based on their own specialty and the particular medical examination they have performed. Multiple such analyses for a single patient are performed by different specialists and subsequently presented in multidisciplinary tumor boards, which are the legitimate decision-making bodies, and a decision is collaboratively made on the most appropriate treatment. On the other hand, research practices are more dynamic in terms of outcomes and impacts, and their scope is broad and aimed at the respective research communities of our experts. The research practices are mostly retrospective and are manifested in the comprehensive analysis of data of patient cohorts. They require minimal to no contact with patients, and the outcomes are aimed towards the generation of new knowledge and also turning this new knowledge into novel treatments. In contrast to clinical workflows where simplistic AI models are used, physicians use a wide range of advanced machine learning and deep learning models in their research practices. In our interviews, we found that physicians' trust in AI was not related to their general acceptance of AI. Our experts unanimously acknowledged their use of AI to support their clinical and research activities, and also responded enthusiastically to AI's future potential in cancer care. Still, in their discourses, their trust, or rather the lack of it, was grounded within the notions of explainability in relation to black boxes and contestability with regards to the development of personal experiences with AI and running validation studies. Both these notions have been a subject of active deliberation in AI research in recent years. Unlike the one-size-fits-all conception of explainability within the AI community, physicians expect explainability to manifest at different levels and aimed at different stakeholders. On the clinical side, the explanations are directed both externally and internally. Externally towards the patient, their family, and in some cases the patient care, and internally aimed at themselves while preparing the diagnosis, and also towards their colleagues while having discussions within the multidisciplinary tumor boards. On the research side, although the explanations are aimed towards the respective research communities of our experts, which may be more accepting of researches, including black boxes, still, there is preference and consistent effort to rely less on black boxes, but more and more on intelligible and handcrafted features with which physicians can relate. To overcome the challenges posed by the operationalization of explainability, recommendations have been made to calibrate clinical practices surrounding the use of AI so that their decisions and impact can be contested. Similar to explainability, in the imaginaries of our experts, contestability also manifests at different levels. On the one hand, by empowering patients to weigh in on the treatment plan and strictly relying on existing standards and norms, and on the other hand, by personally experiencing AI with their own data and extensively validating its performance against their benchmarks. For AI to be meaningfully and properly adopted, HCI and AI researchers should develop synergistic pathways between the clinical and research context and remove boundaries between the global focus of AI and its local deployment. In the imaginaries of our interviewees, AI is expected to be contextual, collaborative, controlled, and conscious. These four attributes enable us to rethink a more appropriate position of AI in the everyday clinical and research practices in cancer care. First, AI is required to be contextual. It conveys that AI requires human beings and their knowledge of the local context, culture, terminology, and workplace practices. In the imaginaries of our experts, for AI to be efficiently incorporated into the everyday practices in the hospital, it must be designed and produced with these practices in mind. Otherwise, it is of limited purpose. Given the variety of working procedures, technical equipment, and established ways of working, the working cultures can be very locally specific. The trust of physicians in AI does not result from it becoming generally accepted. They already use AI in their clinical and research practices, but from their personal relationship to AI, which can then be relied as a sensible working instrument. Second, it has to be collaborative. In cancer care, a collaborative democratic process is already present in decision-making instruments such as the multidisciplinary tumor boards. Therefore, physicians envision AI as a collaborator which can truly augment them by helping them assimilate more multimodal information, by enabling them to visualize latent and subtle aspects of the underlying biology, and by taking initiatives including co-creation and discussions which can help them treat cancers more effectively. Third, physicians expect AI to be controlled. It concerns with the possibility of human overruling AI and making visible any tacit ideologies which are inherently built into AI-based technologies. In the clinical context, the ideological aspect is of lesser relevance. The ideology of medicine is quite straightforward and well regulated by law. The problem is not purely ethical, but also legal, that is, related to the formulation of guidelines and their efficiency. Nevertheless, rather than control as a mechanism protecting the society against the ulterior motives and hidden ideologies of the AI creators, the control over AI in oncology seems to be a matter of service to patients. Finally, physicians expect AI to be conscious. This aspect has to do primarily with problems related to data as a sole representation of reality, and with the production of intelligent solutions based on creativity and progressiveness rather than the reproduction of earlier states of the world. The concern is that the algorithm grounds its outcome in data that physicians can trust, both in terms of quality and quantity. The distinction that seems to be operative is a distinction between one's own data and the institutional data. In the imaginaries of physicians, for AI to be adopted, there should be functional synergies between generalizable statistical categories from the research context and their application to specific patients within clinics. With this, I conclude my talk, and I thank you very much for your attention.